Good afternoon all, and thanks the organizing committee for inviting me. Today's topic is just a debate and a very interesting point. The topic that is the SGLT2 inhibitors, all SGLT inhibitors are same, and I will talk on regarding the motion of this topic. So yes, all SGLT2 inhibitors are same. So we know in the management of type 2 diabetes, its SGLT2 inhibitor is just the magical bullet. Not only the blood glucose control, there are so much other beneficial effect that we can see with this with the use of the SGLT2 inhibitors. So in type 2 diabetes, in the glycemic the reduction, in the heart failure patient, there is in the prevention of the heart failure hospitalizations, and the both primary prevention and secondary prevention, and the CKD patient to reduce the renal disease progression, and so more. That many of things we cannot know about that, and we are very much the debatable in many regards, like the different topics like the MSLD, like the fatty liver disease, etc. So the SGLT2 inhibitor, we know there is so much molecule under this category, that is Canagliflozin, Dapagliflozin, Empagliflozin, Gliflozin, and Remogliflozins. And SGLT2 inhibitor is beyond the glycemic control. So there are many effects we know. So number one is the glycemic reduction. Number two is a non-glycemic metabolic benefit that we can observe, that is the reduction of the body weight, reduction of the blood pressure to some extent, and also to the beneficial effect to the dyslipidemia or the diabetic dyslipidemia, and also to some extent reduction in the uric acid level. Now outside the metabolic benefit, there are some organ benefit we can also observe with the SGLT2 inhibitor, that is to reduce the cardiovascular mortality, to reduce the heart failure hospitalizations, and to reduce the progression of the renal disease progression, to reduce the urinary albumin creatinine ratio. So much beneficial effect we can observe with this molecule. Now do they all work in the same way? So it depends on the different factors. First, the pharmacokinetic and pharmacodynamics we have to discuss about the different molecule. So we see that regarding the bioavailability of the molecule, it is very much important to know about the bioavailability, and on the basis of that the dose requirement is mainly fixed. So the bioavailability is listed with the Canagliflozin, that is 65%, and it is more or less higher in the R2 and the DAPA arm. So Cana dose requirement is high, that is 100 milligram we all know, and the DAPA is 10 milligram. But overall, the reflected patient benefit or the patient efficacy to the diabetic patients is more or less similar to all these, the molecule of EMPA, Cana, DAPA, etc. And there is no such drug-to-drug interaction, and also as per the excretion, the renal excretions is proportions is a list with the Canagliflozin, and the others are more or less same. And on the contraindication to use is more or less equal in all the categories. So there is no major difference between these categories. Regarding the selectivity, we also should be focused on the selectivity to the SGLT2 receptor in comparison to the SGLT1 receptor. So the highest selectivity has been observed with the Empagliflozin, the lowest with the Canagliflozin. So, but ultimately, does the difference actually translate to the difference in the clinical effect in the real world? That is a very much debatable. That clear cut, there is no proper answer in the head-to-head comparison of the efficacy of these 4 different SGLT2 inhibitor molecule due to the differences in the selectivity. So to know that there are some several studies has been seen in the literature. The comparative assessment of the long-term effectiveness and safety of DAPA and EMPA molecule has added to the hypoglycemic drug. After 36 months of treatment, the clinical parameters decrease significantly in this group, and both the parameters, not only the HbA1c but also the body weight, cholesterol level, even the liver enzymes, etc., and also the blood pressures. So all the metabolic factors has been observed a more or less similar reduction. There is no differences between the DAPA and EMPA. So to conclude that there is no significant differences in the efficacy between this DAPA and EMPA. So this is another study of the DAPA, Cana, and EMPA, 3 SGLT2 molecule, and is associated with the significant improvement in diabetes, cardiovascular outcome, and the blood pressure reduction, improvement of the proteinuria, all of which expected to improve the cardiovascular morbidity and possibly mortality. So there is no individual differences between these 3 molecules. As a whole, they have shown the beneficial effect. The pivotal CVOT trials were all known about. These are famous trials. For EMPA, that is EMPA-REG outcome trial. For the DAPA, declare TRIMI. For the Cana is a CANVAS trial. And for the Gliflozin is a VATI-CV trial. Now, in the result of these four these CVOT trials, we have clearly seen that majority of the trials showing the beneficial effect. Like the empiric outcome trial, in all the 4 arms, the hospitalization for the heart failure, CV death, 3-point MACE, and renal outcome, they have shown the beneficial effect. For the canvas is majority showing the beneficial effect, except that is for the CV death, that is not showing the beneficial, there is a non-inferiority, is showing the non-inferiority. Declared TME, they are majority showing the beneficial effect on the hospitalization for the heart failure and the renal outcome, except 3-point MACE and CV death, but this is non-inferior, they are not totally inferior. And what is CV? It is showing the non-inferiority in the majority of the arm and showing the beneficial effect only on the hospitalization for the heart failure. So, in the majority of the cases, for hospitalization for the heart failure and for the renal disease progression prevention, so all the 4 molecules more or less similar with very minute difference in between these. That is not properly statistically significant. But the actual differences we cannot be done due to this is an individual trial, that is not a head-to-head trial between these molecules. So data from the systemic review and the meta-analysis, it has been shown that in the different the subgroup analysis of the different molecule at a different scenario, like in the heart failure, in comparison to the EMPA, the effect of DAPA, Cana, and the other SGLT2 inhibitor, like in the myocardial infarction, in angina pectoris, in stroke, in atrial fibrillation. So all these 4 to 5 cardiovascular morbidity conditions, they have shown that there is a comparable effect or risk reduction between the individual SGLT2 inhibitor. So there is no significant, statistically significant differences has been observed. In the overall cohort also, that is to investigate the individual profile of each SGLT2 inhibitor in patient with different background. This is a meta-analysis showing the similar picture, that is no significant differences between the 5 SGLT2 inhibitor were not observed for the composite cardiovascular death and the hospitalization for the heart failure. And also in the subgroup analysis in the diabetic patients, they have also failed to show any significant differences between each group of the molecule. And also in the CKD patients, patient is having CKD, patient without CKD, in both the arm, there is no significant differences between the SGLT2 inhibitor molecule, between each molecule. The overall the molecule showing the beneficial effect to some extent and to some extent non-inferiority, but no differences in between the molecules. Now also, ultimately, so that is the conclusion that a clinician may be reassured that there was no evidence that a particular SGLT2 inhibitor was consistently more efficacious than the other agent in reducing the cardiovascular or the renal event. Except in some cases for Empagliflozin, it is more preferable in the established cardiovascular disease patients without any CKD, etc. Otherwise, overall we can use in each organ damage like the ASCVD or CKD patients, we preferably using this SGLT2 inhibitor. No particular molecule is preferred for this category. So to conclude that the class effect of the SGLT2 inhibitor, that is the structure of the molecule, more or less similar, all the molecules. Mechanism of action is more or less similar, that is a proximal convoluted tubule at the of the glomerulus, and that is SGLT2 transporter inhibition. Similar pharmacological effect, blood glucose reduction and the other metabolic benefit, cardiovascular benefit and the renal benefit. And in the CVOT trials, we have seen that in the MACE outcome, there is probably this is not a class effect because there are some minute differences between the molecule. But in the heart failure and the diabetic kidney disease, there are no individual differences. It is a whole class effect. There is a significant reduction of the heart failure hospitalization, significant prevention of the heart failure, and reduce the progression of the diabetic kidney disease and reduce the proteinuria. Thank you for the kind attention.